A lot of my patients ask what type of bariatric surgery I would recommend for them. I would say the decision is theirs. Myself and other members of our multidisciplinary team are there to educate you and guide you so that at the end you will be able to make an informed choice with confidence. Your choice is not be based on personal experience of someone else being successful or otherwise. It should be based on facts. Before the turn of the century, hardly any weight loss surgery was done in Australia. For the first 10 years, it was predominantly the gastric band that dominated. As we gained more experience with the long-term results of the gastric band and with emergence of more modern surgery, it quickly fell out of favor from 2010. Currently, sleeve gastrectomy is the most commonly performed weight loss operation in Australia and all over the world. Sleeve gastrectomy accounts for over 80% of the primary surgeries currently done in Australia for weight loss. Gastric bypass surgeries account for 15% and minimal number of gastric bands and other emerging surgeries. These figures are different for revisional surgery. In my clinical practice, overall, close to 60% of patients choose to have a sleeve gastrectomy and the rest a gastric bypass. The main gastric bypass I offer is one anastomosis gastric bypass, with Roux-en-Y, SAR-D, SAR-C operations reserved for specific indications. I expect you to have watched the educational videos on each of the operations you are interested in before coming to this point. Let me recap some of the important points. Sleeve gastrectomy is a strong weight loss operation, at least in the short and medium term, and long-term data are emerging. Roux-en-Y gastric bypass has the longest history and the most available long-term data. Results after one anastomosis gastric bypass is very comparable to the Roux-en-Y. Other intestinal bypass procedures like SAR-D and SAR-C are emerging procedures with only a limited amount of short-term data. In general, changes in your metabolism that drives weight loss is more dramatic after an intestinal bypass procedure than with a sleeve gastrectomy. This means bypass operations are more effective for metabolic disease like type 2 diabetes and insulin resistance. When it comes to maintenance of lost weight, at this point it appears that both sleeve gastrectomy and bypass procedures are quite comparable in the first 3 years after surgery. However, beyond this point, the stronger gastric bypass procedures seem to do better compared to a sleeve, indicating probably the chance of failure leading to weight regain is more common after sleeve. However, before surgery, we have no way of predicting those who do well or fail in the long term. The most common long-term side effects after any type of weight loss surgery is nutritional deficiencies. This is why we have bariatric dietitians to educate you before surgery and help you in the follow-up period. Daily nutritional supplementations and monitoring with annual blood tests are mandatory to avoid this risk. The fact is, for those who do not comply, deficiencies are quite common, and this is more significant after a gastric bypass operation due to malabsorption in the proximal intestine. The most common long-term side effect after sleeve gastrectomy is the risk of gastroesophageal reflux disease. In the long term, about 1/3 of post-sleeve patients need to be on medication for reflux. When medication is not effective, probably close to 5% of them may need further surgery. On the other hand, marginal ulcers, which rarely can perforate or bleed, is a specific complication affecting close to 2% of one anastomosis gastric bypass patients. Main risk factors for ulcers are smoking and anti-inflammatory medication use. Another 2% of post-OAGB patients develop troublesome bile reflux, and corrective surgery is very effective. A key difference between the two is sleeve gastrectomy is not reversible, and one anastomosis gastric bypass is easily reversible and revisable to other procedures. Sleeve gastrectomy is a good operation if you do not have a lot of weight to lose, probably a BMI under 45. If you have ulcer risk factors and unsure about the long-term intake of supplements, sleeve becomes a safer option to consider. If you have had previous open abdominal surgery and high risk of bowel adhesions, sleeve is probably the only safe laparoscopic operation that can be done. If you have a long-term history of troublesome reflux, sleeve is likely to make it worse and is not advisable. Someone with metabolic disease like type 2 diabetes and insulin resistance, a gastric bypass is a better operation with its weight loss independent, hormonally mediated metabolic advantages. If you have troublesome reflux, it is likely to get better after a gastric bypass. Comparative studies have shown for someone with a higher BMI over 50, bypass is a better compared to a sleeve, both in terms of maximum weight loss achieved and ability to maintain the lost weight in the short term. Most patients considering revisional surgery have had experience of reflux and disappointing results with the first operation, which probably indicates a stronger bypass operation is a better option. Out of the bypass operations, my first choice is one anastomosis gastric bypass for good reasons. If a patient has Barrett's esophagus secondary to chronic reflux, Roux-en-Y gastric bypass is probably the best choice. If you have significant ulcer risk factors but still benefit from a bypass operation, SAR-D is a safer choice. However, these are general guidelines only, and your individual circumstances and concerns may be unique. Come and talk to us at WA Weight Loss Center. We are here to help you.